initially it was not working for me. So, at the topic allocated to me is the lumbar sympathetic block and the severe hypogastric block. Well, we know the anatomy as it was, we know there are five the lumbar sympathetic chain. They are on one lateral present, and the majority of the time the L1 and the L2 are fused. So the positioning anatomically also varies in each patient. Even bilateral, they may not be symmetrically placed. So these are the anatomy concerns when we talk about the lumbar sympathetic chain, which is present bilaterally. And as you can see in this anatomy, you have the psoas muscle on the both sides. So this lumbar sympathetic chain is present anterolaterally, but it is medial to the psoas muscle. So when we are doing the procedure, the spread of the dye will be different if the needle is placed in the psoas muscle and different if it is placed close to the sympathetic chain. So the indications, it is a sympathetically mediated pain, any from the viscera, it can be the lower limbs, it can be your CRPS having peripheral neuropathies, any vascular insufficiency, and any post-operative neuralgias of the lower limb. Preparations, or you have to have a maintain a sterile technique, having IV access, which I usually do in my practice, having a long needle because you need to take a long trajectory to reach there, and local anesthetics, and a metal marker and a side marker, because it is very important to have the same side and the same, the orientation once you're doing the procedure. So, counting is a part of the, reaching at the L3. You can choose anywhere from the L2, 3, 4. But then, yes, if you are focusing more on the axial part of the lumbar areas, it's L2. If it's in the sympathetic chain is more, supposed to be on the L3. But if you're targeting for the lower part, it is L4. So squaring with the vertebra, making the same side, having an oblique until you can see the transverse process is hidden behind the body of the lateral body of the vertebra. Then this is an example of a boy who was in my clinic, and this boy received an intramuscular injection in the gluteal area because of some pain the child was having, and following that there was an injury because of the improper injection which was given to the child, and he developed a very initially the pain was shooting in character, and then there were features of CRPS. So this boy, so the procedure is done, the patient was put in the prone position, all asepsis was maintained, and the ipsilateral oblique was done till you can see the transverse process is hitting onto the lateral border of the vertebra, and then the needle was inserted below the transverse process, and until the needle contacts. If it's very superficial, it may be the transverse process, then you go below that. And once you are at the body of the lateral body of the vertebra, then you walk off and you try to make proximity to the vertebral body. Don't go lateral to it. And the depth measurement is possible with the lateral view. And then you can, as you can see in the picture over here, the needle tip is present here. But then you advance the tip, and until the tip of the needle is at the border of the anterior border of the vertebral body. As you can see, the needle is being advanced progressively. But then you have to be very careful. This was a 14-year-old boy. They might be having a pain in the periostome once you scratch the border of the vertebra. So sometimes you have to, if you're not planning a stimulation base, if you're just doing a diagnostic, you can get some local also. And then you can clearly see that it is present at the anterior border of the vertebra. So you give a dye, and then you see the spread of the dye, which is kind of a good spread onto the border. And then one more, confirm it with the AP image. So the tip of the needle in the AP should be in the pedicular. It should be the center of the pedicular channel. So that's another confirmation that you are not too lateral. You're positioning of a needle, and then dye confirmation, like it was done in this patient, was done. And then once you give the local anesthetic as a diagnostic block, you can see the dry is being spread in this patient. A patient was a 77-year-old female in my clinic who had a below knee amputation, and like she was having the symptoms of abdominal pain, and then she was flagged for a diagnostic block. So in this, you can see the degenerative spine that she is having, and you can see the side marking and the position marking, and you can see the, what we talked in the previous one, the transverse process is hardly visible in this. So we can optimize on the image, and the patient was taken up, and the procedure was done under complete asepsis, and further squaring was done, and then the exhalating oblique was done until the transverse process was, could be no longer being seen in that, and just trying to speed up the video actually. So you can see the flora image will be shown now, and in that we are trying to, yeah. So we can see in here the needle is being, trying to hit onto the lateral border of the vertebrae. Then in the next, you can see the image. Then we're taking a lateral view, and we're trying to advance the needle in depth in this patient. So it's being advanced, and then here we will be advancing it, and then in the next we have reached the anterior. I'm trying to speed up this video, sorry. And then we see it on the anterior border, and then you will be seeing the dye spread. So we're going to inject the dye, and it will be onto the anterior border of the vertebrae. Yeah, can you see it now? It's visible here. And then more dye was given, so it's confirmed. Now this is the AP view in which we have confirmed the clarification. Then the local rescue solution, you can see the spread, and this was the patient, like she was very happy with the pain relief. So she was, you can see the amputated lip, and she was very pleased to have pain relief. And that pain that she was she was having a very good pain relief in the resting position, but because due to the degenerative spine, there are other pain generators in this patient. So this is the incorrect position. Just to touch upon the superior hypogastric block, this is again, it is, now you can see, like there is a conference of, the pre-ganglionic fibers from the lower thoracic and the upper lumbar fibers. And then these fibers, they interface with the lumbar sympathetic chains also. So the lumbar splanchnic fibers also join, and then their post-ganglionic fibers. So they have component of both. The location is just, in front of the L4 vertebra, you can see here, and then they descend onto the L5. And these are in close proximity to the, the level is L5 and S1. So there is a target position for your superior hypogastric plexus block. And then the indications are, you can see the indications. The modalities can be blind, it can be fluoroscopic, CT guided, and ultrasound guided as well. So I will only talk about the fluoro because CT I am not practicing. So preparation is again, you have to give in power preparation. If you are going for an anterior approach, particularly USG anterior, then you need to do the power preparation, antibiotics, IV fluids, hemodynamic monitoring, and same prone positioning, inverse squaring. But here there is one, for this is that in this you have the needle direction has to be ordered, and it has to be, you're trying to go from the lateral side and you're trying to approach. So from the lateral to medial, you're trying to come in front of the promontory area. So it has to be, the direction is going to be this, like you're going to be coming from here, but you're targeting this level. So in the lumbar thing, you're going straight, but here you're targeting anteriorly, ordered and medial. That's the difference. Then you are entering at 45 degrees. So here also, when you have done an exploratory oblique, you have done the tunnel approach. The needle will be, just at the junction of your the iliac crest and the superior artery process. Just in the entry, you will be putting your needle, and under tunnel vision, you will be reaching the area and advance the needle. You can go transdistal. You can go 2 needle techniques from each side, and then you can perform the contrast. And complications you have to be, the N5 nerve root injury should be prevented. And thank you so much. That I try to finish.
Yes, but well completed.